A 4-year-old presents with a heart rate of 45 bpm, poor perfusion, and no response to oxygen. What is the next immediate action? A. Begin chest compressions. B. Administer epinephrine. C. Apply transcutaneous pacing. D. Give atropine. Answer A. In children, bradycardia with poor perfusion is treated as cardiac arrest. Chest compressions must begin immediately. Which is the correct compression to ventilation ratio for to rescue CPR in a child? A. 15:2. B. 30:2. C. 10:1. D. 20:2. Answer A. For children and infants, to rescue CPR uses a 15:2 ratio to optimize oxygenation and circulation. A child in shock shows weak pulses, delayed capillary refill, and altered mental status. Which type of shock is most likely if lung sounds are clear? A. Cardiogenic. B. Hypovolemic. C. Obstructive. D. Septic. Answer B. Hypovolemic shock presents with poor perfusion and clear lungs due to fluid loss. A 3-year-old has SVT at 220 bpm and remains unstable after oxygen and monitoring. What is the next immediate treatment? A. Adenosine 4-push. B. Amiodarone infusion. C. Synchronized cardioversion. D. Vagal maneuvers. Answer C. Unstable SVT with poor perfusion requires immediate synchronized cardioversion. The most reliable method to confirm endotracheal tube placement in children is A. Chest rise and fall. B. Auscultation of breath sounds. C. End-tidal CO2 monitoring. D. Fogging in the tube. Answer C. Continuous end-tidal CO2 monitoring is the gold standard for confirming tube placement. During pediatric resuscitation, which drug is indicated for pulseless ventricular fibrillation? A. Amiodarone. B. Adenosine. C. Atropine. D. Dopamine. Answer A. Amiodarone is recommended for refractory VF/pulseless VT in children. Which of the following best describes compensated shock in a child? A. Low blood pressure with weak pulses. B. Normal blood pressure with poor perfusion signs. C. Absent pulses and apnea. D. Cardiac arrest with asystole. Answer B. Children can maintain blood pressure for a long time, showing early signs of shock through poor perfusion before hypotension. A 6-year-old with asthma presents with severe respiratory distress and fatigue. Oxygen saturation is 82% on high-flow oxygen. What is the immediate intervention? A. Endotracheal intubation. B. Epinephrine IM. C. Bag mask ventilation. D. Nebulized albuterol. Answer C. When oxygen fails and the child is tiring, assisted ventilation is needed immediately. A child with suspected septic shock remains hypotensive after fluids. What medication is the next step? A. Dopamine. B. Epinephrine. C. Norepinephrine. D. Atropine. Answer B. Epinephrine is the preferred vasopressor in pediatric septic shock unresponsive to fluids. What is the correct depth of chest compressions in a child? A. About 1 inch. B. At least 1/3 the chest's anterior-posterior diameter. C. About 4 inches. D. No deeper than 2 centimeters. Answer B. Compression depth for children should be at least 1/3 of the chest's diameter, about 5 centimeters. Which rhythm requires immediate defibrillation in pediatric arrest? A. Asystole. B. Pulseless electrical activity. C. Ventricular fibrillation. D. Sinus tachycardia. Answer: C. VF is shockable and requires immediate defibrillation. A 2-year-old has a sudden choking episode and becomes cyanotic. What is the first action? A. Perform back blows and chest thrusts. B. Attempt blind finger sweep. C. Give abdominal thrusts only. D. Start CPR immediately. Answer: A. Infants and small children with airway obstruction need back blows and chest thrusts to relieve obstruction. What is the appropriate initial defibrillation dose in pediatric VF? A. 2J/kg. B. 4J/kg. C. 5J/kg. D. 10J/kg. Answer: A. The first pediatric defibrillation shock is 2J/kg. A 9-year-old presents with altered mental status, cool extremities, and weak central pulses. Blood pressure is low. What is the child's shock stage? A. Compensated. B. Decompensated. C. Cardiogenic. D. Refractory. Answer: B. Hypotension in children indicates decompensated shock, a late and critical stage. A child with anaphylaxis develops hypotension and respiratory distress. What is the most important immediate drug to give? A. Diphenhydramine 4. B. Epinephrine IM. C. Albuterol nebulizer. D. Corticosteroids 4. Answer: B. Epinephrine IM is the first-line, life-saving treatment for anaphylaxis. Which sign best indicates impending respiratory failure in a child? A. Tachypnea with accessory muscle use. B. Loud stridor. C. Decreased effort with bradypnea. D. Wheezing after coughing. Answer: C. Bradypnea with fatigue signals respiratory failure and impending arrest. A 5-year-old with SVT is stable. What is the first non-pharmacological intervention? A. Adenosine 4. B. Ice to the face, vagal maneuver. C. Amiodarone infusion. D. Cardioversion. Answer: B. Stable SVT is first treated with vagal maneuvers like ice to the face. Which of the following is not part of the pediatric cardiac arrest algorithm? A. High-quality CPR. B. Early defibrillation if shockable. C. Giving atropine for asystole. D. Administering epinephrine every 3 to 5 minutes. Answer: C. Atropine is not recommended for asystole in pediatric arrest. Which airway device provides the best protection against aspiration? A. Endotracheal tube. B. Oropharyngeal airway. C. Nasopharyngeal airway. D. Bag mask. Answer: A. Endotracheal intubation provides the most secure airway protection. During pediatric CPR, what is the correct compression rate? A. 60 to 80 per minute. B. 90 to 100 per minute. C. 100 to 120 per minute. D. 140 to 160 per minute. Answer: C. Recommended compression rate for children is 100 to 120 per minute. A child presents with a wide complex tachycardia, pulse present, and stable condition. What is the first step? A. Defibrillation. B. Amiodarone or procainamide. C. Epinephrine. D. Synchronized cardioversion immediately. Answer: B. Stable wide complex tachycardia may be treated with antiarrhythmics before cardioversion. What is the maximum single dose of adenosine in pediatric SVT? A. 3 mg. B. 6 mg. C. 12 mg. D. 18 mg. Answer: C. The maximum pediatric adenosine dose is 12 mg for push. Which sign suggests distributive shock rather than hypovolemic shock? A. Bounding pulses with warm skin. B. Weak peripheral pulses with cool skin. C. Flat neck veins. D. History of trauma with bleeding. Answer: A. Warm extremities and bounding pulses are typical of distributive, septic, anaphylactic shock. A 7-year-old has ventricular fibrillation. After CPR and one shock, what is the next drug to give? A. Lidocaine. B. Atropine. C. Adenosine. D. Epinephrine. Answer: D. Epinephrine is administered after the first shock during VF arrest. Which pulse is most appropriate to check in a child during CPR? A. Carotid. B. Radial. C. Femoral. D. Brachial. Answer: A. In children, the carotid or femoral pulse is checked. Brachial is for infants. What is the correct initial fluid bolus for pediatric shock? A. 5 ml per kilogram. B. 10 ml per kilogram. C. 20 ml per kilogram. D. 40 ml per kilogram. Answer: C. The standard bolus for children is 20 ml per kilogram of isotonic crystalloid. Which finding suggests impending cardiac arrest in a child? A. Tachycardia with fever. B. Weak central pulses and bradypnea. C. Warm extremities. D. Alert mental status. Answer: B. Poor perfusion with bradypnea indicates severe deterioration toward arrest. When performing CPR on an infant with 2 rescuers, what is the correct compression technique? A. 2-finger compressions. B. 2 thumb encircling hands. C. Heel of one hand. D. Both hands overlapped. Answer: B. The 2 thumb encircling technique is best for infants with 2 rescuers. Which lab value is most critical to monitor in a child with septic shock? A. Glucose. B. Calcium. C. Lactate. D. Hemoglobin. Answer: C. Elevated lactate indicates tissue hypoperfusion and severity of septic shock. What is the main goal of PALS in pediatric emergencies? A. Cure all arrhythmias. B. Prevent cardiac arrest. C. Maintain hospital reputation. D. Reduce parental anxiety. Answer: B. PALS aims to prevent cardiac arrest by recognizing and treating respiratory and circulatory failure early. A 5-year-old presents with bradycardia and poor perfusion despite adequate oxygenation and ventilation. What is the first-line medication? A. Amiodarone. B. Atropine. C. Adenosine. D. Epinephrine. Answer: D. In pediatric bradycardia with poor perfusion, epinephrine is the first-line drug because bradycardia is often hypoxia-related. Atropine is considered if increased vagal tone or AV block is suspected. During PALS, when should you consider advanced airway placement in a child with respiratory arrest? A. Immediately upon arrival. B. After 5 cycles of CPR if bag mask ventilation is ineffective. C. Only after drug administration fails. D. Only if the child is older than 8 years. Answer B. If bag mask ventilation is ineffective after high-quality CPR, advanced airway placement is indicated to ensure oxygenation and ventilation. A 2-year-old child is in shock with delayed capillary refill, weak pulses, and hypotension. What is the most appropriate initial fluid bolus? A. 5 ml per kilogram isotonic crystalloid. B. 10 ml per kilogram isotonic crystalloid. C. 20 ml per kilogram isotonic crystalloid. D. 40 ml per kilogram isotonic crystalloid. Answer C. PALS recommends an initial bolus of 20 ml per kilogram isotonic crystalloid, normal saline or lactated ringers, for pediatric shock, with reassessment after each bolus. Which of the following is the most reliable indicator of effective chest compressions in a pediatric patient? A. End tidal CO2 of 10 mm of mercury. B. A palpable femoral pulse during compressions. C. Chest recoil after each compression. D. Visible chest rise. Answer B. While multiple indicators are important, the most reliable measure is the presence of a palpable pulse during compressions, confirming adequate perfusion pressure. In pediatric tachycardia with pulses, synchronized cardioversion is indicated when the child has A. Wide complex tachycardia with no symptoms. B. First-degree AV block. C. Sinus tachycardia from dehydration. D. Supraventricular tachycardia with hypotension. Answer D. Synchronized cardioversion is indicated in unstable tachycardias, such as SVT with hypotension, altered mental status, or poor perfusion. What is the initial energy dose for defibrillation in a pediatric patient with pulseless VT? A. 1J/kg. B. 2J/kg. C. 4J/kg. D. 6J/kg. Answer B. The first defibrillation attempt in children is 2J/kg. If unsuccessful, subsequent doses may be increased to 4J/kg or higher, not exceeding 10J/kg. What is the recommended compression depth for infants during PALS resuscitation? A. 1 inch, 2.5 centimeters. B. 1.5 inches, 4 centimeters. C. 2 inches, 5 centimeters. D. At least 1/3 the chest's anterior-posterior diameter. Answer D. Pediatric compression depth should be at least 1/3 of the anterior-posterior chest diameter, which is about 4 centimeters for infants and 5 centimeters for children. Which rhythm is most commonly seen in pediatric cardiac arrest? A. Ventricular fibrillation. B. Pulseless ventricular tachycardia. C. Asystole/PA. D. Torsades de pointes. Answer C. Unlike adults, children most commonly present with asystole or PA during cardiac arrest, usually due to hypoxia or shock rather than primary arrhythmias. A child in respiratory failure has a heart rate that drops below 60 per minute with poor perfusion despite adequate oxygen and ventilation. What is the next step? A. Give atropine. B. Begin chest compressions. C. Prepare for defibrillation. D. Administer adenosine. Answer B. In pediatrics, if the heart rate is less than 60 per minute with signs of poor perfusion after oxygenation and ventilation, chest compressions should be started immediately. During resuscitation of a 6-month-old, the team notices excessive ventilation rates. What is the major risk? A. Bradycardia. B. Ventricular fibrillation. C. Increased cerebral perfusion. D. Gastric inflation and decreased cardiac output. Answer D. Hyperventilation can cause increased intrathoracic pressure, reducing venous return and cardiac output, while also risking gastric inflation and aspiration. Which drug is contraindicated in pediatric bradycardia unless there is a specific cause such as vagal stimulation? A. Epinephrine. B. Atropine. C. Adenosine. D. Amiodarone. Answer, B. Atropine is rarely used in children and is indicated mainly for bradycardia caused by increased vagal tone or primary AV block, not as a first-line treatment. For a 3-year-old with anaphylaxis and shock unresponsive to intramuscular epinephrine, what is the next intervention? A. For bolus epinephrine. B. For diphenhydramine. C. For corticosteroids. D. For epinephrine infusion. Answer, D. If IM epinephrine is ineffective and 4-epinephrine infusion is started for persistent shock, while other supportive medications can be added but are not first-line. Which of the following conditions is most likely to progress to PA in children? A. Severe dehydration. B. Congenital heart block. C. Respiratory failure. D. Ventricular fibrillation. Answer, C. Respiratory failure is the most common cause of pediatric cardiac arrest and often leads to bradycardia and PA/asystole rather than VF/VT. When using an AED on a child under 8 years old, what modification should be made if available? A. Increase energy dose to adult levels. B. Use pediatric dose attenuator pads. C. Deliver shocks at half the adult dose. D. Apply pads only to the chest wall. Answer, B. Pediatric dose attenuator pads reduce shock energy to a safe level for small children. If unavailable, adult pads may be used, but never cut or overlap them. Which finding best differentiates supraventricular tachycardia, SVT, from sinus tachycardia in children? A. Narrow QRS complex. B. Presence of visible P waves. C. Heart rate less than 180 bpm. D. Abrupt onset and termination. Answer, D. SVT is characterized by an abrupt onset and termination with very fast rates, often without visible P waves. Sinus tachycardia has gradual onset and variability with activity. A 4-year-old child in septic shock continues to have poor perfusion despite 60 ml per kilogram fluid bolus. What is the next step? A. Give another fluid bolus. B. Start epinephrine or norepinephrine infusion. C. Administer sodium bicarbonate. D. Prepare for synchronized cardioversion. Answer, B. After 40 to 60 ml/kg fluid resuscitation, if shock persists, vasoactive support, epinephrine or norepinephrine, is indicated to restore perfusion. Which of the following is considered the most important predictor of survival in pediatric cardiac arrest? A. Time to first epinephrine dose. B. Duration of CPR. C. Time to first defibrillation, if shockable rhythm. D. Use of advanced airway. Answer, C. In shockable rhythms, early defibrillation is the single most important predictor of survival, although high-quality CPR and early epinephrine also play key roles. During pediatric resuscitation, which parameter is most accurate for monitoring effective ventilation with an advanced airway? A. Oxygen saturation. B. Chest rise. C. End tidal CO2, capnography. D. Heart rate increase. Answer, C. Continuous capnography, ETCO2 monitoring, provides the most accurate assessment of ventilation and is also useful for monitoring CPR quality and ROSC. Which intervention is appropriate for torsades de pointes in a 6-year-old with a pulse but unstable? A. For amiodarone. B. For magnesium sulfate. C. Immediate defibrillation at 4J/kg. D. Synchronized cardioversion without drugs. Answer B. Magnesium sulfate is the treatment of choice for torsades de pointes. Defibrillation is reserved for pulseless torsades. In pediatric post-resuscitation care, which target oxygen saturation should be maintained to avoid hyperoxia? A. 80 to 85%. B. 88 to 92%. C. 94 to 99%. D. 100%. Answer C. After ROSC, oxygen saturation should be maintained at 94 to 99% to prevent hypoxia and avoid the harmful effects of prolonged hyperoxia on brain and heart tissue.